Welcome to the Ventilator and Pulmonary Mechanics Chalk Talk series, where we're learning how ventilators work and how to work with ventilators. I'm John McManigal. Let's get started. Last time we discussed optimizing ventilation. Now we're going to finish up this round of how to work a ventilator by talking about oxygenation. We reviewed the causes of hypoxemia in Lecture 8 and saw that to correct hypoxemia, we need to increase the inspired oxygen fraction and the mean airway pressure. Let's review what we know. The alveolar gas equation tells us that, in an ideal lung model, the expected partial pressure of oxygen in the alveolus will depend on the inspired oxygen fraction, the airway pressure, and the alveolar carbon dioxide partial pressure. We also remember our 5 mechanisms of hypoxemia: insufficient inspired oxygen, which would be very unusual in a hospital; hypoventilation, which we talked about in great detail in the last talk; diffusion limitation; ventilation-perfusion mismatch, the most common cause of hypoxemia; and true shunt. As we get ready to consider correcting hypoxemia, I want to address a few preliminary questions first. To begin with, if FiO2 and airway pressure are both in the alveolar gas equation, why does FiO2 help so much with these first 3 causes of hypoxemia, but increasing airway pressure does not? The answer is that it's a matter of scale. Let's work out a quick example by looking at hypoventilation. This is the alveolar gas equation. The alveolar oxygen partial pressure is equal to the inspired oxygen fraction times the alveolar pressure less the vapor pressure of water, that quantity minus the alveolar carbon dioxide partial pressure, divided by the respiratory quotient. Let's look at a patient that's breathing room air with an FiO2 of 21% at sea level pressure, which is 760 millimeters of mercury, minus the vapor pressure of water, which is 47 millimeters of mercury at body temperature. Now, let's say he's hypoventilating to an alveolar carbon dioxide partial pressure of 80 millimeters of mercury. Divide that by the respiratory quotient of 0.8. Just as a shortcut, if you haven't noticed it yet, the inspired oxygen pressure at room air, 21%, and sea level barometric pressure, 760 millimeters of mercury, comes up a lot, and that whole PiO2 term is almost exactly 150 millimeters of mercury, so it might be worth remembering that number if you expect to be running the alveolar gas equation frequently. Anyway, if we calculate this out, it's an alveolar oxygen partial pressure of 50 millimeters of mercury, clearly hypoxic. Let's look at an example of correcting this with supplemental oxygen. If we increase the FiO2 to 50% and leave everything else the same, that works out to an alveolar oxygen partial pressure of 257 millimeters of mercury, obviously completely and even over-corrected. Compare that to trying to treat this hypoxemia by increasing PEEP. In general, PEEP is how we increase the mean airway pressure on a ventilator. Let's go for a pretty high PEEP of 20 centimeters of water. That's not unreasonably high, but it's certainly on the high side of the PEEPs you'll see clinically. 20 centimeters of water is about 15 millimeters of mercury. You might already see the problem, which is that compared to atmospheric pressure of 760 millimeters of mercury, 15 millimeters of mercury, even though it's a pretty substantial PEEP, is not enough to budge the alveolar gas equation much. If we add this to the airway pressure, we get 775 millimeters of mercury, and our alveolar partial pressure of oxygen works out to be 53 millimeters of mercury. So even with an aggressive PEEP, we bumped the PaO2 from 50 to 53 millimeters of mercury, compared to increasing it to 257 millimeters of mercury with a modest FiO2 increase. This is why, even though airway pressure is in the alveolar gas equation, we can't use a ventilator to increase it significantly on the scale of barometric pressure. I'll mention that you can take this to the extreme by using hyperbaric oxygen in those big submarine-looking tanks that allow you to take the patient to 2 or 3 times atmospheric pressure. That will make a big difference in arterial oxygenation, but it's well beyond the scope of a ventilator lecture. The second question is, if increasing airway pressure really only helps in ventilation-perfusion mismatch, why does it always seem to help oxygenation in real life? And the answer to this one is short. There is always VQ mismatch, and there's usually recruitable lung. As we talked about in Lecture 8, the VQ ratios in a healthy lung usually range between about 0.3 and 2. But almost any pulmonary disease process will widen this range, giving rise to low VQ regions. The effect of increased airway pressure is to correct this, both by increasing ventilation in low VQ regions, as well as by eliminating areas of atelectasis that cause shunt. So that leads into the third question. In the list of mechanisms of hypoxemia, what do I mean when I specify true shunt? Part of what makes this confusing is that when people say shunt, they mean two different things. Let's go back to our enormous 5-segment lung picture. As crazy as this is, it's still a wild oversimplification. The total alveolar surface area in an adult is about the size of a tennis court, and each alveolus might have a slightly different ventilation-perfusion ratio. So to simplify this whole situation, and to get some kind of consistent language across lungs, we often fall back on a 3-compartment model. From left to right here, the 3 compartments are pure dead space in compartment 1, perfect VQ matching in compartment 2, and pure shunt in compartment 3. So representing a more complex system, like the 5-compartment lung above, in the 3-compartment model, the dead space, perfectly matched, and shunt segments would be represented by those respective areas on the 3-compartment lung model, and then the in-between areas would be split proportionally between compartments on the 3-compartment model in a way that would be mathematically equivalent to a lung with only these 3 compartments. So this is the utility and the curse of the 3-compartment model. On the one hand, there are various ways, which we won't get into right now, that you can calculate the dead space volume and the shunt fraction for any lung, no matter how complicated. When you do that, the dead space volume is the amount of airway volume in the dead space compartment in this 3-compartment model, and the shunt fraction is the proportion of blood flowing through the shunt compartment in this model. And that's great because it lets you quantify and categorize lung performance. But the disadvantage is that people will toss around phrases like, oh, there's a 10% shunt fraction. And that might make you think that the problem is largely a quote-unquote true shunt, which you can't fix with FiO2 or airway pressure. When in reality, a big part of what's going on is your more fixable VQ mismatch. We might do a lecture later on the calculation of shunt fraction and dead space, but for now, I'll just say that one way to distinguish between true shunt and VQ mismatch is to calculate shunt fraction while the patient is breathing 100% oxygen, because we know that that corrects the effect of low VQ areas. For now, let's just think about 4 scenarios that could all give you a measured shunt fraction of 10%. Any of these, a low VQ segment, atelectasis, purulent pneumonia, or a pulmonary arteriovenous malformation, could all give you a shunt fraction of 10%. For each of these, let's think about whether increasing the mean airway pressure will help, and whether increasing the inspired oxygen fraction will help. In a low VQ segment, we've probably beat this horse enough. Increasing FiO2 will correct the hypoxemia, and increasing mean airway pressure will give you more ventilation in the low VQ segment, which would help as well. In atelectasis, is FiO2 going to help? Well, if you don't have any air going into this collapsed alveolus, increased FiO2 won't help much. What about increasing mean airway pressure? Well, yes, because that would balloon open this alveolus and recruit this segment of lung, resulting in new gas exchange. In purulent pneumonia, with pus in the airway, or in a pulmonary arteriovenous malformation, where blood is bypassing the airways entirely, neither airway pressure nor FiO2 is going to directly help with the hypoxemia due to these segments, because breathing gas never comes in contact with blood. So without further ado, let's talk about how to increase mean airway pressure to improve oxygenation. We're going to start with a patient on pressure control, normal modest settings, PEEP of 5 centimeters of water, an inspiratory pressure, which we remember is measured from PEEP, of 10 centimeters of water, so our peak pressure is 15 centimeters of water. The respiratory rate is 12 breaths per minute, giving us a respiratory cycle time of 5 seconds. We're spending 2 seconds in inspiration and 3 seconds in expiration, which is a 1 to 1.5 IDE ratio. The reason I picked pressure control here is that it's easy to calculate a mean airway pressure. The mean airway pressure is the time-weighted average of the circuit pressure, which in this case is about 9 centimeters of water. So to increase mean airway pressure, we'll almost always go with strategy number 1, which is increasing positive end expiratory pressure. We'll set our new PEEP to 10 centimeters of water from 5 centimeters of water. If we leave our inspiratory pressure at 10 centimeters of water, people will call this in shorthand pressure control 10 over 10 for an inspiratory pressure of 10 over a PEEP of 10. Assuming you stay in a reasonable linear region of pulmonary compliance curves, and until we get into the future ARDS lectures, we'll assume that we are, you're not going to change the shape of the pulmonary pressure curve much. It will just be shifted up by the amount of PEEP that you've added. For that reason, you're also not going to change the shape of your flow curve much, so ventilation won't change much. The only big difference will be the fact that everything on your pressure curve is shifted up by the 5 centimeters of water that you added to PEEP. So PEEP is now 10 centimeters of water, all of your other variables stay the same, and the new mean airway pressure is, as you might expect, 14 centimeters of water. So when it comes to increasing mean airway pressure, that's about as simple as it gets. In terms of trade-offs, the only disadvantage is that we've increased our plateau pressure by that same 5 centimeters of water. To understand some of these trade-offs, and we'll have a whole lecture or two dedicated to this in the future, it's time to start thinking about ventilator-induced lung injuries. These 3 injuries, barotrauma, volutrauma, and atelectatrauma, are the pressure-related injuries. We'll introduce the 4th big injury, hyperoxic lung injury, in just a minute. When we talk about the trade-off of increasing plateau pressure, what we're considering is the risk of barotrauma, which is overexpansion of the lung with high pulmonary pressures. At its most extreme, this can lead to alveolar rupture, pneumothorax, pneumomediastinum, and arterial gas embolism. The other 2 types of pressure-related ventilator-induced lung injury are volutrauma and atelectatrauma. Volutrauma relates to the repeated stress and strain of large breaths over a long period of time, as the lung tissue expands and contracts with every breath. So you're at higher risk for volutrauma in the setting of large tidal volumes and a large driving pressure. Driving pressure is the difference between plateau pressure and PEEP. In pressure control mode, driving pressure is very close to the inspiratory pressure. Atelectatrauma is the tissue damage caused by the collapse and re-recruitment of atelectatic alveoli with every breath. So that is actually worse at low positive end expiratory pressure because the lower your PEEP, the more alveoli collapse during each expiration. So when we increase PEEP to improve oxygenation, we may have increased our risk of barotrauma. Usually we try to keep the plateau pressure below about 30 centimeters of water, although there are plenty of exceptions. We haven't changed our volutrauma risk because we haven't changed tidal volume or driving pressure, and we've hopefully decreased our risk of atelectatrauma because we've increased PEEP. A lot of ventilator management winds up being in a realm with a paucity of evidence, or at least a situation where it's challenging to apply the available evidence to your patient. I'll give a few rules of thumb here about choosing a PEEP in the hope that they'll help you out clinically. First, start with a PEEP equal to the patient's BMI divided by 4 and plan to increase from there depending on how they do clinically. We'll get into chest wall mechanics in a future lecture, but part of what you're doing with PEEP is counteracting the weight of the chest wall and abdomen on the lungs, so bigger people need more PEEP. Second, if you increase PEEP and your ventilator measured compliance increases, it was probably the right move. Most modern ventilators give you a measured compliance breath by breath. So if you increase PEEP and that compliance increases, you probably did the right thing. Finally, if you increase PEEP and your measured compliance decreases, you might be approaching the patient's plateau pressure limit. As you might imagine, elastance goes up and compliance goes down as you reach the patient's upper limit of plateau pressure and lung volume. There is a slightly fancier calculation called stress index that we will, and I hate to keep saying this, get into in a future lecture, which helps us optimize PEEP. But in the meantime, these three rules should get you by. So that wraps up increasing positive end expiratory pressure in order to increase mean airway pressure, which is almost always the right strategy. Let's briefly look at two alternative strategies and why we usually don't pick them. Strategy number 2 to increase mean airway pressure: couldn't we have just increased our inspiratory pressure? In this example, we'll go ahead and leave PEEP at 5 centimeters of water. Instead, we'll increase the inspiratory pressure to 15 centimeters of water and leave our other parameters the same. So what does this look like? We've still increased the plateau pressure by about the same amount as when we increased PEEP, so the risk of barotrauma has increased by the same amount. We've also increased our tidal volume and therefore increased minute ventilation. So this might not be a bad strategy if you have both hypoxemia and hypercarbia because you've increased minute ventilation. But how much have you actually increased the mean airway pressure? Remember that mean airway pressure is a time-weighted average of the circuit pressure. On the left-hand side of the screen, before the change, the mean airway pressure was 9 centimeters of water, and if you do the time-weighted average on the right side of the screen, you'll find that you only increased your mean airway pressure to 11 centimeters of water. I'll flip back quickly to the increase in PEEP, where we got an increase to 14 centimeters of water. So this is the reason we usually don't just increase the inspiratory pressure to correct hypoxemia by increasing mean airway pressure. Although it does increase the mean airway pressure, it does so by a much smaller amount than an equal increase in PEEP, and it generates an equal trade-off in terms of increased plateau pressure and risk of barotrauma. On top of that, it increases tidal volume, meaning that your risk of volutrauma is higher, and if you had your ventilation dialed in precisely, that is now thrown off. You also haven't increased PEEP, so you haven't decreased your risk of atelectotrauma like you did when you increased PEEP. So in real life, if the primary goal is to increase mean airway pressure, we generally do not use this strategy of increasing the inspiratory pressure. There is one final strategy to increase mean airway pressure, and that is increasing the I/E ratio. So let's take a look at that. Right now, on the left side of the screen, the mean airway pressure is 9 centimeters of water, which is the time-weighted average of the green airway pressure curve. So what if we spent more time in the inspiratory phase? Currently, the I/E ratio, the ratio of inspiratory time to expiratory time, is 1 to 1.5, because we're spending 3 seconds in expiration and only 2 seconds in inspiration. But if we changed our I/E ratio to 1 to 1, so we're instead spending 2.5 seconds in inspiration and 2.5 seconds in expiration, how would that change things? Well, we would still have the same plateau pressure. There's a risk that we would develop auto-PEEP, because we know that's always a risk when we decrease expiratory time, but the way that we've drawn out the physiology here, it won't quite happen, which is good. And what about mean airway pressure? Now that our inspiratory pressure and expiratory pressure times are equal, the time-weighted average is 10 centimeters of water, up from 9. So increasing the I/E ratio doesn't get you much in the way of mean airway pressure, especially compared to increasing PEEP. However, it is an interesting strategy to have in the back of your mind, because as we've seen, you haven't increased your risk of barotrauma by increasing peak pressure, you haven't increased your risk of volutrauma by increasing driving pressure, and you haven't increased your risk of atelectotrauma. So if you were able to make this change without developing auto-PEEP, you've essentially got a tiny bit more mean airway pressure for free. In general, if you're in a pressure control mode with a well-sedated patient and trying to get as much mean airway pressure as possible, there's very little downside to using the maximum I/E ratio possible that still avoids auto-PEEP. At this point, we've exhausted the ways to increase mean airway pressure. Now, let's talk about fraction of inspired oxygen. We looked at the alveolar gas equation enough that you know that increasing the inspired oxygen fraction will increase your alveolar and arterial partial pressures of oxygen. So why don't we just put people on 100% oxygen and call it a day? Unfortunately, prolonged exposure to high inspired oxygen concentration can cause pulmonary oxygen toxicity, especially at FiO2 greater than 60%. This is mediated by hydrogen peroxide and free radical formation, and it looks clinically a lot like ARDS. The toxicity is dependent on both the FiO2 and the time of administration. It's usually not seen before 24 hours of ventilation, even on 100% FiO2. The lower the FiO2, the longer the toxicity takes to develop. And again, below 60% FiO2, most patients won't develop issues. So the usual strategy is to start the ventilator up at a very high FiO2, often 100%, immediately after intubation to compensate for the apneic period during intubation. Then, over the next several minutes, do your best to optimize your ventilation and PEEP and bring your FiO2 down to the lowest level that will maintain an arterial oxygen partial pressure in the range of 60 to 65 millimeters of mercury, or pulse oximetry between 90 to 95%. You'll also find that often we switch to 100% FiO2 to give the patient some reserve in the couple of minutes around a stimulating procedure, like when you're turning the patient or changing their bed sheets or immediately before extubation. And that's probably okay as long as it's just for a few minutes. Finally, let's talk about the particular patients where you might want to stay on the high or low end of the FiO2 spectrum. You'll find that a lot of people advocate for high inspired oxygen fraction in patients experiencing acute ischemia, like in an actively developing myocardial infarction or stroke. There's been some research showing no difference in all-cause mortality with supplemental oxygen above 90% saturation in ST segment elevation myocardial infarctions, so at least it doesn't seem to hurt. Another time you might keep your arterial oxygen tension high, even if it means relying on higher FiO2, is if there's a combination of active hemodynamic instability and a threatened perfusion watershed. The classic example of this is during a big spine surgery with significant bleeding. On the other hand, there are several instances when you want to be extra conservative with FiO2. Following on the ischemia example, you definitely want a very modest arterial oxygen tension immediately after reperfusion, either of an MI or a stroke, because free radicals play a big role in reperfusion injury. You definitely need to keep both inspired oxygen fraction and arterial oxygen partial pressure low in neonates, as they contribute to bronchopulmonary dysplasia and retinopathy of prematurity, respectively. And finally, there are certain drugs, most notably bleomycin, which is a chemotherapeutic agent used in leukemia and germ cell tumors, that can immensely increase your risk for oxygen toxicity. So if a patient has ever taken bleomycin, you should forever keep their FiO2 as low as possible. Before we finish up, I think it's worth taking just a minute to look at where we've come so far. We built up our mental model of a ventilator really from scratch. We looked at compliance and resistance as the major mechanical laws that drive the circuit pressure and gas flows in the ventilator, literally getting breathing gas in and out of the patient's lungs. We've gone through really the whole gamut of conventional ventilator modes. We then dove into some respiratory physiology, looking at the mechanisms of hypercarbia and hypoxemia. And now, in these last two lectures, we've really tied it all together and looked at how to use a ventilator to correct hypoxemia and hypercarbia by improving oxygenation and ventilation. So at this point, if your goal is to go out there and intubate somebody for airway protection and keep them alive on a ventilator, really, if you have a patient with pulmonary physiology that is anywhere close to normal, you're now well equipped to manage it. Next, we'll expand our understanding to patients who have extremely challenging respiratory physiology. We'll spend a few lectures talking about ARDS, the acute respiratory distress syndrome, and all of the challenges it brings. We'll also consider extreme obesity and severe obstructive disease. And to build the framework for some of this management, we'll take a few deep dives into some topics that we haven't covered yet. We'll look at things like non-conventional ventilation modes, heliox, and proning. So while we finish this first chapter of ventilator management, we've still really only scratched the surface of the bigger story. As always, thanks for your attention, and I'll see you next time.